Okay, so let's see how we start the station. History and communication skills. So whenever you enter into the cubicle, you have to greet with the smiley face. You will see like in any OSCE exam, smiley face will do I would say a lot of wonders for you. I mean, you have to be very careful. I mean, if the station is breaking bad news, of course you are not going to smile in that station. But otherwise, if it is simple history station, counseling station, examination station, it would be really good if you go inside and you are having a smiley face. Smiles are also of different types. So don't be very sarcastic, but yes, a genuine smile on your face would be very helpful in developing the rapport and making your patient more comfortable with you during the consultation. Right, so greet simply by saying hello. You need to introduce yourself. You need to identify your patient. So you need to introduce yourself. For example, hello, my name is Ankur. I'm the doctor's here. So that's how you introduce yourself. And you need to identify the patient. You need to confirm the identity of the patient by saying, hello, my name is Ankur. I'm the doctor's here. May I confirm your name, please? And then patient will be able to tell you his or her name. That's how you have to proceed in the station. Right now, you have to see like, for example, the name of the patient is James Hopkins. So just a hypothetical name. So for example, patient says, Doctor, I'm James. So what you will say after that? Yeah, hello, James. Nice to meet you. And you will start the station. If patient says, I'm Mr. Hopkins. Hello, Mr. Hopkins. Nice to meet you. What I mean to say, Mr. will go with Hopkins, not with James. Mr. James is not something. It's nothing actually. Mr. Hopkins will make sense. So it's James or Mr. Hopkins. Let's see how patient will confirm his or her identity, and accordingly you will proceed in the station. By any chance, if a patient mentions to you that I'm I'm James Hopkins. Now it's a bit confusing. Should we use James or should we use Mr. Hopkins? It's always better. What I would say, it's always better. Give this chance to your patient. Ask the patient, what would you like me to call you? Yeah, doctor, you can call me Mr. Hopkins. Hello, Mr. Hopkins. Nice to meet you. Right. So that's the best way like you can introduce and you can identify a patient. Moreover, you will see the name of the patient is written outside the cubicle as well. Right, so you already know the name of the patient. So why we are identifying? Because it's compulsory. And instead of saying, could you please confirm your name? Even if you want, you can use the name which is written outside. For example, it's written outside the cubicle. James Hopkins, 40 years old, came to the hospital because of chest pain. So you can start like, hello, my name is Ankur. When the doctor's here, are you Mr. Hopkins? Yes, doctor. Hello, Mr. Hopkins. Nice to meet you. That's also fine. There is no hard and fast rule that you have to go only and only by this way. There can be a different way that you can that you can have in your exam, right? But make sure just choose one and make yourself comfortable with that approach, right? And in the exam, you have to be very careful regarding your sitting plan as well. For example, your patient is sitting. If your patient is sitting, you will just go and sit. If patient is standing, because in some of the station you might see like your patient is standing because the patient is anxious, the patient is angry, the patient is very much worried about their dear ones. That's the reason patient is standing. So when you go, you will also be standing. You cannot sit unless your patient is sitting. So what you do, you'll try to calm down your patient and try to make him or her sit, and then only you will sit. Right. So what happens if patient is sitting, you will sit. If patient is standing, you will be standing, and you're making your patient comfortable, and then you will make your patient sit, and then only you will sit. After that, for example, like patient is lying down on the couch, because you will see in these kind of OSCE exam, you will see many patients, they're lying down on the couch because, for example, this is a post-op case, this is pre-op case, the patient is, it's accidental case. So you'll see like, it will not make sense if they're sitting or if they're standing. I know they are simulators, they're professional actors, but they have to do good acting. So they'll be lying down in some of the stations. So in that case, it is entirely up to you whether you want to sit or you want to stand. It's entirely up to you. The thing is, the moral of the story is you need to make eye contact with them. If you feel like sitting, I can make eye contact, that's fine. If you feel standing, it's better, that's also fine. No hard and fast rule. And there is, this is very quite common question that we come across is, should we shake hand with the patient or not? See, it is entirely up to you. It is entirely up to you. You need to see the patient. Sometimes they are sitting in this kind of posture, like a bit angry maybe. So maybe it's not a good idea to shake hand. Other than that, any history counseling station, I would say it is good to shake hands, but again, it's not like compulsory. It is up to you. If you want to shake hand, do it. If you don't want to shake hand, that's absolutely fine. But one thing is very important. If you want to shake hand, make sure you are very much confident. Shake hand. It's not like your hand is shaking while you want to shake hand. No, shake hand with confidence. Otherwise, don't even try it. So this is very, very important. And the first minute of the station, it's very important. I would say it's a golden minute, right? So patient will be giving you lots of information, and also examiner will be looking at your confidence level at this first golden minute. So please don't mess up this first golden minute. It will actually decide whether you fail or pass the station. Very, very important. So we have greeted the patient, we have introduced ourselves, we have identified the patient, and then we'll start. What brings you to the hospital? How can I help you? And then patient will start, and make sure you listen to the patient carefully, because patient, they are not going to simply say, doctor, I'm in pain. No, they are going to tell you lots of information, but make sure you do not interrupt them. It's pretty common when patients say, doctor, I have pain. Oh, I'm sorry to hear that. Are you comfortable to talk? Meaning, do not interrupt the patient. Because, patient will tell you one line, doctor, I'm in pain. It's been like few hours. I started having pain in my chest. What I mean to say, they will be giving the information slowly, but if you will interrupt them, they will not be feeling like giving you more information. So please let them talk without an interruption if you really want to have good time in the exam, right? So please take care of this golden minute. Be very careful. Do not interrupt them. Let them talk. Let them give the enough information, and always start with open question, right? That's our history and communication skills. So in history taking, we have to take care of a few things. First, we have got presenting complaint. Then you need to elaborate the presenting complaint, history of presenting complaint. First, presenting complaint, elaborate that presenting complaint. And then you have got associated symptoms. So when you're elaborating the presenting complaint, you will be having an idea what's going on with this patient. So what you need to do, you need to ask associated symptoms to confirm your diagnosis, right? And make sure you're ruling out few differential. We're not saying rule out so many differential, but at least 3-4 differential would be really nice to rule out. And make sure the differential you are ruling out, they are very important. They are emergency differential. I would say they are killer differential. If you will not rule out, maybe you are missing something which can kill the patient. So very careful. Presenting complaint, elaborate the presenting complaint, ask associated symptom, differential diagnosis, past medical history, personal history or lifestyle history, I would say, and social history. That would be the pattern, and we'll discuss one by one about all these steps. So what I mean to say, history taking, when you are having a presenting complaint, and we need to elaborate that presenting complaint. For example, we are discussing about chest pain. Patient has given you a complaint, chest pain. So what we did, we elaborated the chest complaint. Elaborated chest pain. So patient said chest pain. We asked the patient, tell me more about chest pain, and patient has explained, patient has elaborated the chest pain. Whatever he hasn't mentioned, we will elaborate that. After that, what we need to do, we ask the patient anything else. If the patient has got anything else with chest pain. For example, like in chest pain, if you're thinking about MI, we ask about cough, we ask about sweating, shortness of breath, tiredness. All these things we have got in our mind, and we need to ask to our patient to confirm our diagnosis, that is, it is ACS, it is angina, it is MI, right? So what we do, chest pain, we have elaborated the chest pain. After that, we ask anything else. Patient says cough. For example, patient said cough. So what do, you elaborate the cough as well. After elaboration of cough, you ask another question, anything else? And patient said, no doctor, nothing else. Now what you do, you have done presenting complaint, you have elaborated all the presenting complaint. We had presenting complaint as chest pain, we had presenting complaint cough. We have elaborated these two. Now you need to ask associated symptom. After elaboration of chest pain and cough, you will be coming to a diagnosis, a rough differential or provisional diagnosis. Now to confirm, if you're thinking it is ACS, it is MI, you ask other question. Do you have any sweating, any shortness of breath, any tiredness? So let's see patient is giving us any of these positive things or not, right? So that is what is your associated symptoms. And after that, make sure you are ruling out few differential, like chest pain differential. Chest pain has got so many differentials, like you have got differential from heart, like we have got MI, we have got this ACS, isn't it? We have got lots of things from the lungs, heart, lungs, like you have got PE, pulmonary embolism, that can give chest pain. You have got pneumothorax, you have got aortic aneurysm, that can give chest pain. You have got pneumonia, that can give chest pain. Lots of things. I mean, even gastric problems also, like say GERD, like tummy discomfort, or that can actually give you chest pain as well. So what you need to do, you need to rule out few differential according to the history of the patient, rule out few emergency killer differential, and then we go for past medical, personal and social history. So make sure we are following this pattern when we are taking history, right? Thank you.